Well, welcome everybody. And this is the first webinar of the IASP's in Partnerships for Life, the global initiative to prevent suicide. We've changed the format this year, which is going to be, the webinar is going to be bi-monthly, and one of the regions will be hosting the webinar. I'm Dr. Murad Khan. I'm Professor of Psychiatry at the Aga Khan University in Karachi in Pakistan. And I've been, until recently, the coordinator of the Partnership for Life for the Eastern Mediterranean region. The objective of the Partnership for Life, also called PFL, is to establish an international collaboration of experts supporting the development of comprehensive strategic approach to suicide prevention at national level. We know suicide is a very complex issue, and almost all countries struggle in suicide prevention. So collaboration is the key, really. Now, the PFL is run by teams in the 6 WHO global regions, along with the IASP central office. And today's webinar is hosted by the Eastern Mediterranean region. We have about an hour, and there will be 3 speakers, all from the region, which is really great. We have Dr. Marjan Fathi from Iran, Dr. Nazish Imran from Pakistan, and Ms. Mahatab Al-Hajj from Lebanon. These might be the settings from which we don't hear too much about. So I think it's great that we're having a diverse group of people talking to us from the EMR. All of you who are here, you may have posed questions already, but if you haven't, you can post your questions in the Q&A section. Try and use the Q&A button rather than the chat button, because it might get lost in the chat one. And we will take the questions at the end of each of the, after all the 3 presentations. And we'll try and address as many as we can. Just to remind you that this webinar is going to be recorded, and it will be uploaded to the IAS website and will be available as soon as the technical issues are resolved. So maybe a couple of weeks or so, so keep checking the website. So without much further ado, I'd like to introduce our first presenter, who is Dr. Marjan Fathi. Dr. Fathi is a health psychologist and a suicidology researcher at the Iran University of Medical Sciences in Tehran in Iran. And Dr. Fathi has over 30 years of expertise in mental health, suicide prevention, and global advocacy. She's been the past secretary and the vice president of the Iranian Society for Suicide Prevention, and she is the incoming coordinator of a Partnership for Life for the Eastern Mediterranean region, and will be taking over from me. So Dr. Fathi's title for today's talk is Social Determinants of Health and Suicide Prevention, Lessons from a 2-year study in Iran. Over to you, Dr. Fathi.
Hey everybody, thank you, Professor Murad. I'm trying to share my screen right now. Good morning, good evening, everyone. Welcome to this Partnership for Life webinar on social determinants of health and suicide prevention. This is the lessons from a 2-year study in Iran. I'm Dr. Marjan Fathi, and today I'll share insights from our mixed method evaluation in Imam Hussein town. This presentation is dated February 24, February 26, 2026. But as we are presenting on the 25th, note that our data remains current. Let's dive in. I'll cover background, methods, results, and implications in about 10 minutes, and leaving time for questions. Okay, background and suicide and social determinants of health. Starting with the basic. Suicide is a global crisis, ranking as the 13th leading cause of death according to WHO 2021 data, claiming around 3,000 lives daily. social determinants of health play a massive role, influencing 30 to 55% of health outcomes through factors like economic stability, education, housing, social support. Key risks include poverty, unemployment, abuse, and easy access to firearms, while protective elements like marriage, religion, and strong social connections can buffer against these. This stage for why addressing social determinants of health is crucial in prevention efforts, especially in suicide prevention. Slide 3, please. Suicide and social determinants of health overview. Building on that, let's overview how social determinants of health impact suicide. Socioeconomic status, education, support system directly shape mental well-being. Lower status often correlates with higher stress and isolation. Poverty and social isolation amplify risks, underscoring the need for community-based support. Effective prevention must integrate these determinants, recognizing how they interact in daily life. For instance, in resource-limited areas, isolation can turn manageable stressors into crises. So, our strategies focus on holistic interventions. Slide 4, please. And slide 5, please. I think slide 4 is okay. Thank you. How about suicide in Iran? In Iran, suicide rates vary regionally. Provinces like Ilam and Kermanshah see higher incidence due to the socioeconomic pressures and unemployment. These disparities highlight how local factors drive national trends. Our national program addresses this through data collection, awareness campaign, enhanced services, media guidelines, and research. Government initiatives are ramping up mental health support nationwide, but gaps remain in underserved areas, which is why we piloted in Islamshahar. Slide 6, please. This map shows Tehran provinces, the capital of Iran, and the yellow mark shows Islamshahar. As you can see, Islamshahar County is located in the southwest of Tehran, with the population of about 600,000 in 2022. Many different people live in Islamshahar. Azeris, Persians, Gilaks, Lors, Kurds, and Mazanis. And it is considerable because many Afghani and Pakistani immigrations live in Islamshahar, work there. It's suburban and underserved, facing challenges like poor infrastructure. We selected Imam Hussein town in the Islamshahar, which is located in the central district of our pilot. Its 2021 suicide rates was 16.3 per 100,000 people. The county's highest, making it ideal for testing social determinants of health-focused intervention. Slide 7, please. Study settings and rationale. Imam Hussein town has around 30,000 residents as of 2024, with persistently high suicide rates, as I said, 16.3 per 100,000 in 2021. it is above the national average. Rational, poor quality of life metrics, such as air quality, employment issues, load of immigrants, and so on. Compound risks. There was a clear gap. No prior Iran-specific social determinants of health interventions existed. So we drew from global model like Peru's ESCAPE, ECAPS, and program in China and South Korea. We adapt them to local needs for a culturally sensitive approach. Slide 8, please. Objectives and methods. Our objective was to evaluate a multi-domain interventions targeting data needs assessment, awareness, services, and infrastructure to reduce suicide rates and address social determinants of health. We used a mixed method design, quantitative via screenings and stats, qualitative through focus group. We screened 257 individuals who referred to the healthcare system for mental health risks. Tools included the Minister's Suicide Registry, Social Determinants of Health Questionnaire, and CSQ-8 for evaluating their satisfaction. Analysis involved chi-square test, logistic regression, and thematic coding. Interventions ran from 2022 to 2024, and the evaluation was done in 2024. Slide 9, please. Interventions. The interventions had 5 pillars. First, we do data enhancement through a multi-sectoral register involving health ministry systems, hospitals, police, firearms control, welfare hotlines. Needs assessment was the second step. We did it via field visits, focus group discussion, and social determinants of health screenings. Awareness. We do it through workshops and material distributions. Services boosted mental health screening by 22%. With better referrals and follow-ups. Infrastructure improvement included sewage, schools, parks, crisis shelters, and so on. Collaborators spanned health networks, education, police, welfare, and more for integrated impact. All organizations, governmental and non-governmental organizations engage in this research. And slide 11, please. After, okay, you can see in this table what we had done, implementation steps in the center of table. Okay. They are all we have done during 1 year. I don't know if you can see them. Okay. Slide 12. Okay, you can see the pictures of what we experienced during this study. And next slide, please. Okay, there are sport campaigns. Next slide, please. Infrastructure upgrade. Next slide, please. Improvement of streets and walkways. And next slide, please. Okay, you can see the form of city in the right side. is the shape that, no. Okay. The right slide shows what we were confronted with, and the left slide shows the streets after intervention. Next slide, please. The very big park and lake, which was built during our interventions. Next slide, please. And crosswalk lighting and access creation, which people asked for them. Next slide, please. Okay. After intervention, we evaluate satisfaction and predictors. We have done it by CSQ8. The result shows the positive screening group showed higher satisfaction, with social services predicting positive outcomes at an odd ratio of 14.7. On social determinants of health, physical harm increased risks, but emotional abuse surprisingly reduced reported risk, likely due to underreporting from shame or stigma. Overall, satisfaction was moderate to high, with needs in health, housing, and education pointing to the intervention's client-centered strengths. It should be considered there is a reason that positive screening groups showed higher satisfaction because we were in touch with them directly. Slide 12, please. Slide next. Yeah, okay, thank you. This table shows the satisfaction criteria. Next slide, please. And key result. Key outcomes. Suicide deaths dropped from 16.37 per 100,000 in 2022 to 3.6 in 2024, an 80.83% reduction in the town, far outpacing the country's 34.85%. It means in the county which we were doing just Ministry of Health strategies, we have decreased in suicide rates. But in Islam Shahr, in Imam Hussein, the reduction was much more higher. How about attempts? Attempts fell from 150.57 to 88.85 per 100,000, a 69.47% drop. We screened 10,247 in 2022, with 5% positive for issue. Social determinants of health differences were significant. Positive reported more economic barriers, abuse, validating our focus on social factors as drivers of improved mental health metrics. Next slide, please. You can see the table. In slide 14, you can see how the suicide rate gets changed in the city and in the county. Next slide, please. Okay. The success stems from our community-based social determinants of health focused model, proving effective in resource-limited setting. It aligns with global evidence like the PCAPS model in Peru and interventions in South Korea and China. Limitations include self-report bias and our study's limited geographic scope. We suggest implement longitudinal tracking and digital tools for real-time monitoring. For the future, we suggest scale this to diverse populations and strengthen intersectoral collaborators to sustain gain. Next slide, please. In conclusion, our integrated interventions slashed suicide by over 80%, underscoring social determinants of health role in scalable prevention. Thank you to Tehran University of Medical Sciences and the Ministry of Health and community partners. It is approved by Ethical Committee of Tehran University of Medical Sciences, and I'd love to discuss how this applies to your context. Thank you very much.
Thank you, Dr. Fathi, for a really interesting presentation. We'll hold the question and answers till the end, and if you have any questions, please write them down or post them in the Q&A section. So we'll move on to our next presenter. It's my privilege to introduce Dr. Nazish Imran, a colleague who is the head and professor in the Department of Child and Family Psychiatry at the King Edward Medical University in Lahore in Pakistan. Dr. Imran is a fellow of the Royal College of Psychiatrists of the UK and completed a PhD in psychiatry with a thesis on school mental health. The special areas of interest include autism spectrum disorders, suicidal behaviors in children and adolescents, and school mental health. Today, she will be talking on Behind the White Coat, Suicidal Behaviors in Pakistani Medical Students. Dr. Nazish, over to you.
Thank you so much. Am I audible? Yeah.
Yes, you are.
Okay.
And we can see your slides.
Yeah. Thank you so much, Professor Murad, and it's an honor to be part of this group and present something which is very close to our heart. And when I was asked to be part of this webinar, the reason why I chose this was that over the last 2 to 3 months, in Pakistan, we have seen several serious student suicide cases and attempts, especially in Lahore and across Punjab, the province where I am based in. And they have caught a lot of media and public attention. And I will come back to some of those cases towards the later part of the presentation. So what I will do is I'll quickly look at some of the background and results of 2 very simple projects related to medical student suicide, and then the recent incidents and reflection and some observation from those suicide incidents and how we can move forward, and would love to hear from all of you regarding the suggestions. So as I mentioned that there has been a recent cluster of student suicide in the province where I'm based in the last 2 to 3 months. And these incidents have been multiple across different universities, both public and private sector, and they do suggest that they are not random events, rather they are systematic issues. We do know from the literature that overall healthcare professionals as well as medical students, they do have much higher rate of depression, anxiety, burnout, and suicidal ideation than age-matched peers. And a lot of typical risk factors like burnout, exam stress, financial difficulties, and lack of support have been cited as some of the reasons. Another very important area, especially in conservative Islamic country like Pakistan, there is a lot of societal stigma related to mental health as well as suicide. And it still remains a very sensitive issue, difficult to talk about, and especially the culture of silence and medical training increases that stigma. And as medical students are the future healthcare provider, their own mental health and their suicidal behaviors also has an impact on the future health workforce and patients' care. So with this background, I'll just share some of the results of the first study, which was published in Middle East Current Psychiatry. Its open access journal is available. That was the work which we did towards the second phase of COVID, around 21, and was published in 22, 23. We mainly one wanted to look at, there were a lot of concerns, the university closed, the hospitals were, our hospital where I'm working in, it's one of the largest public sector hospital in Punjab, and our hospital was mainly the COVID center, the first one in the whole province. So our outpatients units remained closed for almost 1 year. The classes later on shifted to online, like the case in majority of the medical institutions. Clinical training got affected. The electives the students had planned, they got disturbed. So there were a lot of concerns regarding the mental health impact of COVID in the medical students. So we wanted to study and see how we can support them. So following the ethical approval from the university and the participating institution, it was a multi-center study in which 5 medical colleges, 3 public sector and 2 private medical colleges in the province where I'm based in. We collected data from there. The questionnaire was developed and was shared via online link. There was written consent. It was anonymous. Answering the question would be considered as consent to participate in the study. All the students were assured of confidentiality of their responses, and they were also given a 24-hour contact number as well as email of the research team whom they can reach out to if they are feeling distressed and needed any emergency services. Also, all the areas where we were working, several local resources and support sources were given within the questionnaire. So overall, 1,100 students participated in this. The questionnaires which we used were focusing on anxiety. We used GAD-7. We used PHQ-9 for the depressive symptoms, and we used risk assessment suicidality scale to assess the suicide risk, because these were some of the tools when we did the literature review were used very frequently. The risk assessment suicidality scale is a 12-item self-report measure, and it has 3 subscales which are relevant to intention, to the life and history of the suicide attempts as well. So 1,100 students with almost 70% were females. We do have a very huge female population in the medical colleges in Pakistan. Mean age was around 23 years, and 27% of the students reported having previous psychiatric problems. As you can see, almost 50% of the medical students in this 1,100 sample, they scored above the cutoffs for anxiety and depression on GAD-7 and PHQ-9. And there were more adverse mental health impact among the females, among the preclinical students, and students who had previous history of psychiatric illness. Along with that, when we looked at risk assessment suicidality scale, the results were quite concerning, because 1 in 5 medical students thought that it would be better if they were dead. Almost 8% admitted to often thinking of dying by suicide if they had the chance, and the duration was the 2 weeks prior to when they were responding to the survey. And these results were these impacts were more in female students, and again, the students who had previous history of psychiatric illness. However, between the clinical and preclinical, in that data, we did not found any difference in the suicidal risk in these 2 groups. We also looked at the PHQ-9. As you know, one of the question is regarding suicidal ideation. And again, in that, almost 12% of medical students admitted to having suicidal thoughts nearly every day, with another 13% having thoughts on almost half the days in the last 2 weeks before they responded. So these were quite concerning results. And following that, once we analyzed, apart from we were getting some calls or some emails along the way, but following that, multiple webinars, because it was still closed, webinars and services webinars were conducted across, mainly focusing on medical students, engaging the students' mental health support network, which was already in some of the institutions. We did a lot of some resource development, which was shared, the questions which the students asked. So we got in touch with our faculty and responded to those questions. The booklet was shared on social media as well as among medical students group. And there was more sensitization of the faculty as well regarding the impact which the medical students were facing. The second paper is, we submitted it almost a year ago, but was published just last week. we looked at, because Pakistan does not have any suicide registry, there is no structured sort of way of getting the data. So we wanted to look at what do we know currently about those medical students who die by suicide. This is again available on the open access and available on the journal website. So by using the keywords of medical student suicide, death by suicide in Pakistan, we just sort of searched on the different media, and we looked at newspapers, websites, and social media for 10 years, 2013 to 2023. And what we found was that 12 cases of suicides were reported. One case was there was some suspicious circumstances later on was declared as homicide, so we excluded that one. Another one was there was not very clear sort of verdict about suicide, so we excluded two. So among the 10 cases, we looked at whatever data was available on any of these sites, whether it was newspaper, whether it was reported in social media, and 8 were males, 2 were female students. Most of the suicides occurred in prior to COVID in 2019 and then followed by 2022. And almost 7 students were from the clinical years. So there were 3 students from final year, there were 3 students from third year, and 1 student of the fourth year. And almost 4 suicides happened in hostel or just nearby the hostels. The methods when we looked at, there was hanging was the highest sort of means of suicide, followed by firearm and then jumping in front of train, and then incident was falling overdose. Although there is no single factor, but because there was very limited information available, there was no psychological autopsy, no detailed analysis in those cases. But what was mentioned in these reports, there were 3 cases where failure in exams was mentioned. There was one case in which depression was clearly mentioned. There was one case because of family conflict, and there was one in which the victim was blackmailed because of false marriage certificate. So these were the most likely the precipitating factors which were available from the data. As we know that sort of this is in line with the previous sort of data that clinical years are more, the students who are in the clinical years are at high risk. There is increased difficulty level of academics as the year go by. Then there is increased burnout, there is increased rates of depression, emotional exhaustion, and aptitude, because in Pakistan, majority of the institution do not have an aptitude test. So based on the marks in the previous, they get admitted, and majority of the time it's the families wish. So aptitude for becoming a doctor for clinical work is often overlooked, and sometimes when they go in clinical year, whether that can be one of the factor increasing risk in the clinical years. Then there was very marked sort of gender difference, although overall national what we know is that it's around male to female is 2:1, but in this sort of higher number of males. Whether it was a reporting, we do not know. But in the cultural context, the traditional roles of masculinity, which affects male experience, leads to perhaps delayed help seeking. And talking about emotions is societal factors might would have contributed to more depression and not help seeking in time. And then the post sort of education, the job prospects might would have contributed to it as well. And another important thing was that all the 4 suicides happened in hostel and in the dorm, what we say. So majority of these students, especially in the public sector hospital institutions, what we see in Pakistan, they usually belong to far-flung rural areas, and majority of them shift to for the medical education to the main cities. They come out of their home into the larger cities for the first time, living in hostel alone, away from the families as well. So we do know that social connectedness is a very important protective factor, and isolation and being adjusting into a new environment might would have contributed to risk of mental health issues in the population who are living in hostel away from home. While we were doing these work, some of the systematic gaps which we identified was that there was no formal mental health screening system in place, confidential counseling confidential counseling was not available. Unfortunately, still very punitive academic culture is often seen in medical institution, and stigma around mental health and access to care is another issue. And then irresponsible reporting of suicide in media, including social media, was noticed in majority of these when we were looking through these reports. Now, coming to the recent incidents, as I mentioned, just sort of 10 days ago, 10 to 12 days ago, 22-year-old final year medical student at one of the public sector university in Lahore died by suicide after jumping from the fourth floor of her hostel while appearing during her exams. So she had an exam that day, and then she has still had, and university immediately suspended the classes and all the exams following that incident. Another sort of law, I think 2, 3 weeks prior to that, in our own university, one of the student attempted suicide by taking overdose, remained admitted, and then there was another incident just 3 days ago in which a postgraduate resident attempted suicide in our university, both living in hostels. Then earlier in December 2025, towards the end, a pharmacy student at a private university in Lahore died by suicide after jumping from the campus building. There were a lot of students protest, and a formal inquiry by the education department was conducted as well. And within a week of that incident, another student, female student from the same university, attempted suicide by jumping from another building. So these two happened within a gap of 1 week. Then recently there was a suicide attempt at a private medical institute in Narowal, again jumping from the second floor. And so there have been multiple incidents in the last 2 to 3 months. And while sort of I was going through those, some of the observations which I would like to share with you, which were very important for learning from these incidents. One was institutional unpreparedness. There was lack of clear crisis response protocol. There was no visible emergency mental health response teams. There was delayed or absent official communication. And then the institutions in some cases were closed without any structured psychological support plans. The other one was weak or absent post-pension planning. There was no immediate grief counseling for the classmates or the hostel mates, and there was limited outreach to the vulnerable students, and the risk of contagion was not proactively addressed. Another issue which we noticed was there was immediate blame-focused inquiries. There was immediate framing around that who is responsible for this. There was defensive institutional responses which we noticed. In one of the sort of situation in our own institution, one difficulty which we found, there was cancellation of hostel allotment. So the student was living in hostel, she was admitted in hospital. There were home conflicts which led to that. Uh, there were financial crises, and the hostel administration was just canceled the allotment. They said we don't want her back here because of the risk, because of concern, and because of the home difficulties. She was supposed to be discharged to home where there were a lot of stressors which contributed to the suicide attempt in the first instance. There were financial issues. So we were at loss as to how to go about it and what we can do and how we can support the student. Then irresponsible media reporting, there was circulation of video, even the jumping of the girl who died by suicide, how the body was dragged on the floor. So all those videos were circulating in social media. There were sensational headlines. There was lack of adherence to the responsible social media reporting. And last but not least was significant communication gap. Apart from 1 or 2 incidents where there was official communication from the institute properly, otherwise, there was no timely official statements. Students were relying on rumors and social media for the information. There was absence of reassurance or mental health resource sharing. So these were some of the things which we noted just in the last 2 to 3 months. However, there have been some encouraging signs, some positive things as well. These have led to increased institutional discussions about students' well-being, about development or strengthening of counseling cells. There have been a lot of mental health awareness sessions happening in university. They have started faculty sensitization workshop. The Pakistan Medical and Dental Council issued statement as well that there needs to be more focus on students' mental health services within the different institutions, especially universities. So these are some of the things, but sort of going forward, I think it's not just one thing. The response has to be at different levels. So at the individual level, improving the mental health literacy for students, peer support programs, and focusing on the gatekeepers training. In our institution, we have started working with the hostel sort of staff who are not medics, the people who are around, whether we can help them identify the warning signs and how we can encourage the help-seeking attitude among the medical students. At the institutional level, there has been focus now on confidential counseling service development, focal persons named, and how the students can contact them. There is significant need to sort of curriculum change and reducing the toxic competition and very punitive culture, which does exist, unfortunately, still now, and the pass-fail system where feasible can help, and faculty training in student well-being is another way. And then moving on to the national and policy level, from what we've learned that PMDC is now issuing some guidelines on students' well-being. There is mandatory student mental health units are being considered, surveillance database, whether that can be established, and more research funding towards student mental health, and doing some qualitative work to understand how we can support them and what are the issues, challenges to learning from them, and engaging them in that discussion rather than making policies without their involvement. And last one, but not least, again, is the post-vention and crisis response. So what to do after a student suicide happen and how we can avoid the contagion effect, provide grief counseling to the people who are affected, and try to ensure that as much as possible, responsible media reporting and official communication can be part of the response. So these are some of the thoughts, and I'll be happy to take any questions or any answers give any answers at the end. Thank you so much.
Thank you very much, Dr. Nazish. That was an excellent presentation on an area that is largely ignored in suicide research, I would say. And this is obviously a very valuable cohort. Not only are they young, but they're also medical students, future doctors. So it's a huge loss to the society and the country. We will move on to a third and the last presentation. It's my pleasure to welcome Mahatab Al-Hajj. Maha is based in Beirut in Lebanon. She's the research coordinator at Embrace. Embrace is a non-governmental organization that operates the National Lifeline in Lebanon for emotional support and suicide prevention in partnership with the National Mental Health Program at the Ministry of Public Health. Maha leads the research initiatives on suicide prevention, crisis intervention, and mental health delivery, mental health service delivery with a strong focus on social determinants. So today Maha is going to present on the mental health in times of crisis, insights from Lebanon's National Suicide Prevention Lifeline. Over to you, Maha.
First of all, thank you so much, Dr. Khan, for that introduction, and it's really nice to see you again. Hello, everyone. My presentation is going to be, as mentioned, about mental health in times of crisis. And as just an overview, the Lifeline 1564 in Lebanon is an anonymous telephone service that operates 24/7, and it's built in collaboration with the National Mental Health Program at the Ministry of Public Health, and it's co-hosted by Embrace, the NGO. And some of the service we provide are immediate emotional support and psychological crisis intervention. And we, of course, assess for suicide risk, and we de-escalate suicide crises. We also provide orientation to community-based resources, depending on what the caller might need, from mental health services to shelter or medical aid. And we also dispatch the National Mental Health Emergency Response Mechanism, or the mobile crisis teams, for psychiatric emergencies if need be. And just as an overview, this is a look at the total number of calls received to the Lifeline within the last 3 years. I would like to highlight the difference between 2025 and 2024, specifically the end of 2024. We observed a decline in the number of calls, and this was due to the intensification of the aggressions and the war that was happening in Lebanon. And usually we see...
Sorry to interrupt. Are you
Sure.
showing the slides? Because we can't see your slides.
Oh, you can't see the slides?
No.
Okay.
Sorry about that.
No worries. Thank you for letting me know.
Did it come on early when you first started and then they disappeared?
Okay, let me just... Can you see them now?
Yes, we can. If you can put them on slideshow, yes, we can.
Okay, perfect. So as I was mentioning, this is a graph that shows the total number of calls received to the Lifeline within the last 3 years. And I was highlighting the end of 2024, which is when we observed a decline in the number of calls that we were seeing. And this proceeded to the beginning of 2025. And then we started to observe the number of calls increasing by around 30% near the end of 2025. And this makes sense, and it's in line with global literature of during times of crisis, calls to national lifelines might decrease because survival takes precedent. And now we're seeing the aftermath of that on the number of calls. And so what I want to talk about today in specific is 3 studies that we conducted to look closer at how the operations, the callers, and even the operators were handling crisis during these times. And so we conducted 3 studies on 3 different levels. Like I mentioned, we wanted to see how the Lifeline operators were affected or not affected by burnout during these times. We also wanted to see how the staff, operating the Lifeline were handling these challenges, and also what the callers were experiencing during these times. And so, as you know, I mentioned the war, but Lebanon has also gone through so many different crises, from the COVID-19 pandemic that the whole world had experienced to the 2020 Beirut port explosion, and then the severe economic collapse that's continuing to today with over 90% currency devaluation. And we mark loosely that the war ceased at the end of 2024, but aggressions do still remain even till today. So that is important to also highlight moving forward. And so I'm going to go over the studies very briefly, just to be mindful of the time. But the first one, like I mentioned, aimed at assessing burnout levels among Lifeline operators. And we specifically were looking at operators that were active during the war period. And we wanted to identify individual and organizational factors associated with burnout. And what we did is we administered a cross-sectional online survey, and we obviously were collecting the data anonymously. We administered the Maslach burnout inventory, assessing for the emotional exhaustion, depersonalization, and personal accomplishment aspects of their experience. We had a sample of 51 operators that were able to respond. And due to the small sample and the unique demands of mental health crisis work, we defined burnout more broadly as high or moderate emotional exhaustion and depersonalization, combined with low or moderate personal accomplishment. And according to this definition, 9 operators met the criteria for burnout. And so that's around 17%, or 1 in 5 almost. And on average, the operators reported moderate emotional exhaustion, low depersonalization, and moderate personal accomplishment. We also were looking at some factors that predict these subscales, and holding another job was a really big predictor of emotional exhaustion by an OR of 4. And then there were some other protective factors: high satisfaction as an operator, having a positive perception of organizational response to these crises, having intrinsic motivation, and having a sense of connection with the callers, or presence of a chief operator on shift, for example, were all protective against emotional exhaustion. And then for low personal accomplishment, a predictor was perceiving post-war calls as more challenging. And a protective factor was professional development opportunities being present within the organization for the volunteer. And so these findings have a lot of implications for practice. For instance, we would want to look at early identification and prevention strategies because, as I mentioned, around 1 in 5 operators seem to be suffering from burnout, and it's important to be catching that early on. And we would want to strengthen the role satisfaction that they have, as it is a very important protective factor, as well as fostering intrinsic motivation and ensuring that they feel connected to the callers so that it can buffer against emotional exhaustion. We would also want to address the burden of many volunteers holding multiple jobs through scheduling flexibility or workload adjustments to be able to reduce burnout risk. And clear shift communication and the presence of a chief operator who can support the staff and make sure that they are confident in their ability to take these calls and connect with these callers in times of crisis and in high stress contexts is important as well. Expanding professional development opportunities in the context of the NGO to enhance personal accomplishment and maintain the quality of emotional support provided for these operators is an important implication. And then mainly in conflict settings, even moderate burnout levels can impact performance and can impact crisis line effectiveness as a whole. So making sure that the staff well-being is sustained is a key operational priority moving forward. And the second study is on the level of staff. And what we did is we explored the experiences of staff and supervisors working at the Lifeline during 2024, during the escalation of the war. And we wanted to understand how they manage responsibilities under crisis conditions and identify key stressors encountered during the conflict, as well as examine strategies used to support the teams and maintain service continuity. What we did is this was a purely qualitative study. We interviewed Lifeline supervisors, managers, and mobile crisis team staff that were active during the war. We did semi-structured interviews that were conducted remotely, and we explored their roles, stressors, how they conducted supervisions, service continuity, and their preparedness or feelings of preparedness. And thematic analysis and content analysis was conducted. So the thematic analysis revealed three overarching themes, which are emotional and psychological toll of war, operational challenges during the crisis, and then coping and support mechanisms. And these themes reflect the participants' experiences balancing the personal trauma with professional responsibility during armed conflict, which is a very tricky line to maneuver, especially when it comes to moral injury, which we'll talk about a bit later. In brief, these are the themes that came out, and this is the thematic map. I'm going to go over the main themes very briefly. Like I said, emotional and psychological toll of war was one of the biggest ones. Psychological distress and mental health challenges and experiences of loss and disruption were sub-themes. We had some staff tell us that they weren't feeling safe emotionally, being present with the operators and supporting them. Some were sharing stories of loss, that they lost a cousin, they lost 2 friends, their village was damaged. Even more so, someone was telling us that they lost their house and their passport, their medical diploma, everything was gone. And that they were feeling already so exhausted because of their exposure to details about the callers and about the calls who had already lost so many things. The second main theme is the operational challenges during crisis, housing sub-themes of infrastructure and logistical constraints, workload and pressure, high-stakes decision-making, and ethical dilemmas. So examples would be we couldn't insure an ambulance. We had to get creative. This is the mobile crisis team speaking. We were overwhelmed. Did we affect this patient by not going? Were we supposed to go? This is in relation to not dispatching the team to a red zone or a high danger zone. I was working maybe 18 hours per day, sleeping 2 to 3 hours. And then questions like, should we put the team at risk in a region that could be bombed? Were things that came up in interviews. The third theme is coping and support mechanisms, housing individual coping strategies and collective and organizational support as sub-themes. So staff were also sharing that they had to block all of these emotions and tackle things professionally. Some were telling me that they were talking to other colleagues and trying to understand how they're feeling. I remember calling a colleague just to tell him I wasn't good. Um, Even it went as far as someone mentioning that the NGO president helped me find a place to stay after my house was bombed. She was a strong support system. And some were even more individual coping mechanisms like meditation, relaxation therapy, and implications for practice. We can learn a lot from this. One is that we need to embed workforce protection and supportive supervision to make sure that staff well-being is a core policy and is a priority by embedding psychological support, structured supervision, and ethics reflection into crisis protocols to prevent burnout and moral injury. So making sure that it's part of the standard operating procedures. And moral injury is defined as the emotional and psychological response characterized by shame, guilt, fear, and anger when individuals face ethical decisions or situations that violate deeply held values, which is what we were seeing during these interviews and, on the ground, where questions of we don't have enough resources to aid this client or this beneficiary. Maybe we would not be able to be dispatched, or maybe it's a danger to send the staff out to this red zone. Maybe it's better that we don't. So these questions were a cause for moral injury for some of our staff, and integrating these things into a standard operating procedures is essential. We would also need to strengthen organizational preparedness and operational standards. So aside from that, we need to adopt clear contingency plans, role redundancy, as some people were working overtime, as mentioned, and simulation-based training to ensure consistent and high-quality decision-making during crises. We also would want to promote regional learning and cross-sectoral collaboration, so institutionalize helplines as essential health infrastructure through regional knowledge sharing and cross-sector policy integration. As we all know, suicide is not just like a health concern or health sector concern, but in times of crisis specifically, it becomes even more so a cross-sector issue. And we also would need to ensure sustainable and diversified funding, because securing predictable long-term financing and strategic partnerships would help protect service continuity and reduce reliance on individual sacrifice, like the staff were having to do. And the third study, aiming at exploring the psychological and socioeconomic stressors reported by callers to the Lifeline during the war. We also wanted to identify key patterns of distress and understand how individuals cope with the suffering in the context of conflict. The study design included 20 randomly selected call recordings to the Lifeline, and it was also a qualitative study. The sampling ensured diversity across gender, call duration, region, and displacement status. And calls that were flagged for war-related distress were translated from Arabic and transcribed verbatim. And the thematic analysis led to these themes, which are economic hardship, emotional and psychological distress, barriers to mental health services, coping mechanisms, social and institutional disconnection. And these themes highlight the multifaceted impact of war on individual well-being, particularly as people navigated displacement, economic collapse, emotional trauma, and weakened systems of support. So this is an overview of the thematic map of caller experiences and responses during the war. And I'm going to briefly go into just part A and part B for the sake of time. So part A was the primary analysis, zoning in on war-related stressors. So one of the main sub-themes here were housing insecurity and displacement, as well as trauma and emotional distress linked to war. So a lot of our callers were reporting that their houses were destroyed. Some were saying our life is over, our stuff is gone. The repeated displacement was also an issue during these calls. We came here and settled in the South because we had a war, and now there's even more war in the South. You know the situation. And even reporting on the situation during displacement, we're sitting on top of each other. I can't handle it, because we were getting also a lot of calls from shelters. And some were also talking about their emotional distress during that time. I was so anxious from the bombs that my husband took me to the hospital to the intensive care. And the secondary analysis was looking into the broader or exacerbated challenges like exacerbated economic hardship, emotional and psychological distress, barriers to support and connection being even more so exacerbated, and then callers sharing their coping mechanisms during their time. And we also noted that the coping mechanisms became way more limited and their resources became way more limited. So callers were also telling us the price of one bag of bread I do not have in the context of I would not even be able to pay for therapy. Some callers would tell us that to cope, sometimes I would hit myself, or for example, I bite my hand. If I had money, I would have gone to therapy, done anything to help myself. And as coping, some callers would say, I make food, I marinate chicken, add broccoli and green peas. I distract myself. So all of this to say that there's a lot of work to be done when it comes to suicide prevention and crisis settings. And some of the things that this study helped us see is that we need to integrate socioeconomic support through cross-sector collaboration again, linking mental health services to humanitarian, legal, and housing support via updated national referral systems is something that we need to work on and are beginning to work on. And this is especially critical for displaced or economically vulnerable individuals. We were getting a lot of calls from people. As I mentioned, we orient callers to community-based services. So a lot of callers were calling the Lifeline to be oriented to shelters or any housing that they could reach, for example. Ensure institutional continuity and sustainable capacity. As mentioned, we need to maintain clear communication and service availability during disruptions, secure stable funding and trained workforce, and also include trauma-informed and humanitarian distress training for the hotline operators to be able to connect better and aid callers better during these times. And we also need to develop culturally grounded interventions. For example, we might be able to build on protective cultural anchors like spirituality, religion, and family responsibility, which enhances trust, relevance, and community acceptance, as a lot of the deterrents that callers were mentioning during this time was religion, for instance. And finally, we could leverage hotline data as early warning. So use call patterns and data patterns to identify emerging risks and unmet needs, and share anonymized data with public health and humanitarian agencies to guide crisis response. And that would be it for me. And I'm happy to take any questions.
Thank you very much, Maha. That was a fascinating presentation, more so because it appears that not only are you dealing with suicide crisis calls, but there's an added layer on which no one has any control, which is the war, and I presume it's mostly the aerial bombing rather than the ground war, which may be in the south of Lebanon, but mostly it's aerial bombing. You didn't mention sorry, I'm just jumping into the question. You didn't mention the pager explosions that happened in Lebanon, in the significant events that you had written. I would have thought that would also cause a lot of distress amongst people.
That is true. We had that was noted in a lot of our internal reports and even published reports, but in lieu of the many attacks that happened even after that, we just summarized it to be the attacks and aggressions in general.
Okay. So Simon and Kezia, I can't access the Q&A section. I don't know if there are any questions in there.
There was one question from Nicholas Proctor, which I think Murad and Nazish, I think you've addressed in the chat, but I don't know whether you would want to expand on that. So the question is, in some settings, suicide deaths reviews and psychological autopsies are acceptable methods for understanding why suicide deaths are occurring within groups. Can you comment on the cultural considerations of these approaches? What, if any, sensitivities or barriers exist surrounding use of these methods?
Yeah. Dr. Nazish, would you like to answer that?
Yes, like sort of there have been psychological autopsies done in Musa has done it. I did try it once to do that, but there were a lot of resistance. There was a lot of reluctance, even to get a detailed history from the families or to get in touch with the friends and so on. It's quite costly as well. So you need a lot of resources to do the psychological autopsy, but most of the time there is a lot of reluctance, especially in case of medical students. Like one of the suicide which happened 10 days ago, we are hoping that we would be able to address that by a psychological autopsy if possible. Regarding the attempt which happened in our university, we did manage to get some of the understandings by interviewing some of the people, having a session from the class fellows and so on, but not in the structured psychological autopsy way, because as far as the institutions are concerned, there is a lot of reluctance. There is a lot of fear that the institution name will be dragged. So trying to understand, it's not easy to get permission from the institution as well at an individual level because of stigma. I don't think it's easy to do in Pakistan. That has been my experience.
Yeah, I agree with you. Um, any other questions? I can't see any in the chat, but I don't know if there are any in the Q&A.
There are no further questions in the Q&A at this stage.
Okay, Maha, if I can ask you, what is the referral pathway that you have once the call comes to your lifeline, and if they need further help, what is the referral pathway that you use? Do you have one?
Sure. Well, it would help to define what further help would be, and it could be three different things. On the case where someone would just need to be oriented to a community-based service, like seeking a mental health professional for low fees, for instance, our job as operators would be to link them. So it's not really directly referring them, it's just giving them the contact number, and the caller would contact the professional on their own time. On the other hand, if we receive calls where there are protection concerns, for example, child protection concerns, gender-based violence concerns, or things of the sort, so more vulnerable callers, these calls would be routed to our social worker. We have a social worker at the Lifeline who would then handle this case as a case management case, with the consent of the caller, of course. And then the third case where someone might need further help would be needing the dispatch of the mobile crisis team. So this would be someone who is either in acute psychosis and is a threat to themselves or others, or mania, or someone who is we went through the protocol and they are still thinking of ending their life, or an active attempt. So with their consent as well, we would dispatch the team to their address, and then there would be an on-ground intervention.
So just a follow-up question to that. I mean, you cover the whole of Lebanon. So if it is in a far-flung area, would you know the local services there that you can dispatch if the person is imminently suicidal?
So with our mobile crisis team right now, we don't operate in all of Lebanon. It has been a gradual scaling project. We operate in 3 regions currently, and we're hoping to scale up. We're doing some research on the scalability of the project. For the time being, if we are unable to reach the caller in a specific area, we would dispatch other alternative services like the internal security forces or the civil defense, for instance, and the Red Cross if need be.
Okay.
Yeah.
Okay. All right. If there aren't any more questions, we've gone over time. It's 12 past the hour. So just want to thank all the 3 speakers. Dr. Fathi had to leave, but if there are any questions for her, please email. She's put her email in the chat box. But I'd like to thank Dr. Fathi, Dr. Nazish Imran, and Maha for really excellent presentations. It's an area that we don't hear too much about. I'm talking of the Emro region in general. It was really fascinating to hear these diverse presentations. What it really highlights, and I think you've, at least 2 of you, Dr. Fathi and you, Maha, have addressed the social determinants of suicidal behavior in some way. And Dr. Nazish has also alluded to systemic issues rather than individual factors. It really is it's important that we learn from each other. We look at not just the individual level factors, but what is happening in the society as a whole, study local factors, and try and come up with strategies that would address the unique characteristics and factors that operate in those settings. And I think it's only by knowledge exchange of this type within the regions and across regions that we can perhaps learn from each other and come up with strategies of a problem that is still a huge challenge in this 21st century. 700,000 people around the world killing themselves is not a small issue, majority of the young people. So let's keep this conversation going. Let's keep the discussions going. And I'd like to thank all of you for attending, and once again to thank the speakers and the team at IASP for organizing this. Thank you very much and good luck. Thank you.
So much.
Thank you so much. Take care.